What's up, guys? My name's David Warren. Welcome to my channel. I'm a travel nurse practitioner. I'm on an assignment in remote Alaska right now, and I'm going to take you to work with me in the ER. If you're new to this channel, consider subscribing, and let's go to work. Welcome to one of the most beautiful parts of Alaska. Thank you so much for watching this video. Again, if you're new here, consider subscribing, give this video a thumbs up. And today I want to talk to you about what it's like to work in the emergency department as a nurse practitioner. Again, my name's David Warren. I have been a nurse practitioner for about 6 years, exclusively in the emergency department, and it's my passion. I love it. I can't see myself doing anything else, and I want to share that with you and tell you what it's all about. I think to work in the emergency department, it takes a particular person. It takes somebody who functions well under stress, who can deal with the chaos, who can see multiple patients at one time, and who can juggle multiple things at a time. And not everybody's cut out for that, and that's okay. But if you are cut out for it, you're a special person, and you belong in the emergency department. Typically, emergency department providers work a variety of shifts. We're not set on like one single shift. We work day shifts, we work mid shifts, we work night shifts. There's just a variety of shifts that we work. And so whenever I first show up to work, first thing I do, always get some coffee. Have to get some coffee. You can't function in the day without coffee. And oh gosh, I don't even know about coffee. I drink so much of it. Coffee's like my go-to thing, so always get coffee when I come in. Usually I'll go see whatever provider is going off shift, and I will take handoff if they have a patient that they have seen that they haven't dispoed yet, meaning they haven't discharged or admitted. I will kind of take over for that patient, and so they can get out on time. That's not always the case, because if you work a mid shift, you're not necessarily going to be relieving anybody. But if you work a morning shift or a night shift, you probably will be relieving somebody. And so I'll take report on whatever patient or patients that they have left or receive handoff. I'll usually go introduce myself to the patient. Sometimes we'll do bedside report or bedside handoff and talk about what's pending, what's been done, and what needs follow-up. And then I will just add that patient to my list of patients to see. And then from there, I will kind of scan the tracker board on the electronic health record, and I will figure out who needs to be picked up. And so, as you know, or maybe as you don't know, in the emergency department, people aren't seen based on first come, first serve. People are seen based on acuity. So the sicker you are, the more life-threatening your illness or injury is, the quicker you will get seen. And so we scan the track board and look for who needs to be picked up next. If there are multiple patients that need to be seen, I will usually choose the patient who's the sickest, and that's based on a triage scale, so 1 to 5. 1 being the most acute, the most life-threatening, 5 being the least acute and the least life-threatening. And so we'll just kind of go in order, picking up patients based on their acuity. I'll sign up for a patient. Sometimes I'll have a scribe, sometimes I won't have a scribe. A scribe is simply a person who is usually in college or who's wanting to go to like nursing school or medical school, and they will do our charts as ED providers. And so the scribe will come along with us, so they'll go see the patient, and they'll do all the charting. So they'll write the HPI, they'll chart the review of systems, they'll chart the physical exam, and then they'll chart the medical decision-making portion of the chart. And so we'll pick up a patient and we'll go evaluate the patient, and we'll get a good history, do a physical exam, and then after I'm done seeing that patient, I will usually go back to my desk, or if I have a laptop, I will throw in some quick orders on the patient. If it's an abdominal pain, then we think about what could be causing the patient's abdominal pain, and based on their history and their physical, we'll kind of figure out what direction we want to go and put in some orders, whether it's labs, imaging, a CT scan, an X-ray, an EKG, some meds, some fluids, whatever they need, we'll put in, and then we'll go on to see the next patient, sign up for the next one. You just keep going, signing up for patient. Usually pick up about 5 to 6 patients at a time. When I first get on shift, I'll go see those patients, and then by the time I've seen the 5th or the 6th patient, I will usually follow back up on the first patient. So I'll take a look at their labs to see if any imaging's back, and then I will go see the patient, go reevaluate them, do like a reassessment, see if they need anything, if they need more pain medicine, they need more nausea medicine, whatever it is, follow up on the patient, do a reassessment, see how they're doing. And that's kind of how the day works. Around mid-shift, we'll take a lunch break, go eat, and then we'll just get right back to it. So the emergency department's an interesting place because, again, sometimes you get some really, really sick people, and sometimes you don't get some sick people. And so that's our job in the ER, is to figure out who's sick and who's not sick. You can think of the ER as like a big sorting bin. It's basically our job to determine, does a patient need to be admitted to the hospital or can they be discharged home? And so that's really what it comes down to. Does the patient stay or does the patient go? And that's really where practicing emergency medicine becomes more of an art than anything, because you're not always going to be able to tell, based on talking to the patient, who needs to stay, who needs to go. But you usually have a pretty good idea about, who needs to be admitted and who can be discharged. And that's really where some providers get in trouble. They don't have a good sense of, who needs to stay, who needs to go. And that's really where you can mess up if you're not thinking, and you send somebody home and they come back with a bad outcome. You don't want to do that. And so you need to be on your game, and you need to be thinking about what's going on with this patient and what do they need. And that's another big thing. Our job in the emergency department, again, is to sort these patients out, determine if they need to be admitted or if they need to be discharged. But also, every time you see a patient in the emergency department, you need to be thinking, what is life-threatening about this patient? And as providers, we can't get the tunnel vision. Tunnel vision is where you focus on one thing, and the patient comes in with chest pain, and you just automatically assume it's anxiety. You can't do that. As a bedside nurse, bedside nurses can get kind of bad about saying, oh, that's just anxiety. It is what it is. Don't worry about it. As providers, we have to think a little more broad, think about what can actually be killing this patient right now. So whenever the patient comes in with chest pain, you want to know what things can kill the patient with chest pain, whether it's acute coronary syndrome, it's a PE, it's a pneumothorax, it's tamponade, it's a ruptured esophagus, whatever it is. You have to be thinking about those things. They have to be on your differential. And so whenever you see the patient, maybe you rule a lot of that out just based on their history, but maybe you can't. Maybe you need to run some tests, check some labs. And that's where, you start choosing what you want to focus on. If you think the patient has acute coronary syndrome, you want to get an EKG, check a troponin, get a chest x-ray, maybe get a repeat EKG in a couple hours, give them aspirin, give them nitro, whatever you need to treat that patient. We can't get tunnel vision though. Every patient you see, you really have to think, what can be killing this patient right now? What is their emergency? Even if it's a level 5 fast track patient, be thinking about what can be killing this patient right now. And you want to rule that out. So our job in the ER is not to get to the bottom of a diagnosis. Our job is to rule out a life threat. Once we've ruled out life threats, the patient can be safely discharged home. If we can't rule out a life threat and we think something more serious is going on, then the patient is ultimately admitted to the hospital. And so that's kind of how the ER works. As an ED nurse practitioner, I do a lot of procedures. So I do lumbar punctures, manage airways via intubation, endotracheal intubation. We put in central lines with ultrasound guidance. We use bedside ultrasound to help us diagnose conditions. We do arterial lines when indicated. We even run codes. So, in the ED, you really have to be prepared for whatever may come through the door. You have to know your ACLS and your PALS algorithms like the back of your hand. So whenever you get a really sick patient that comes in that's coding, you know exactly what to do. And you have to be really good at putting in central lines and doing lumbar punctures. There's just so many procedures that you have to be good at. And that's the beauty of the emergency department, is you get to see a little bit of everything and you get to do a little bit of everything. And it's so fun. Okay, let's talk about managing some patients. I want to talk about managing unstable patients. So whenever you first go see a patient, the first thing you want to know is the patient's airway patent? And a very easy way to tell that is whenever you walk in the room, just talk to the patient. Ask them what their name is. Ask them how they're doing. If they can give you an adequate response, then they have a patent airway. The time I get concerned is whenever I go into the patient's room and they're not really responding and they're kind of moaning around and they don't really look so hot. So the next step would be to go up to the patient and give them some sort of physical stimulation. So do a sternal rub, pinch their nail, shake them, try to get them to respond. If they wake up and they start responding, then you're golden. Their airway's patent, you don't have to worry about it. However, another way to tell is, if they are not responding to you, open their mouth and stick a tongue depressor back in the back of their throat. If they have a gag reflex, then they're protecting their own airway. If they don't have a gag reflex, that's a sign of concern. And at that point, I would get set up for taking over the airway. So providing endotracheal intubation to secure that airway, because that's not a safe airway if the patient doesn't have a gag reflex. So airway, first thing is go talk to the patient, see if they'll respond to you. If they will, you're golden. Don't worry about it. The next thing, breathing. Is the patient breathing? That's the first question you want to ask. So again, look at their chest, see if they have chest rise and fall. They should be on the monitor, check their oxygen saturations, listen to their breath sounds, see if they have adequate respirations. Are they not breathing very fast? Are they breathing super shallow? Are they tachypnic? Just see kind of what their respiratory status is like, and then tailor your treatment based on that. So if they are not breathing, grab the bag valve mask and breathe for them. If they are breathing and they're hypoxic, put them on some oxygen. If you listen to their lungs and they're wheezing, put them on some albuterol. There are just some basic things that you can do to just quickly run through an assessment. And the next thing you want to do is obviously circulation. Is the patient bleeding from anywhere? If they're not a trauma patient, they're probably not bleeding. Again, this is not really trauma focused, but circulation would encompass that. So stop the bleed. Take a look at the patient's skin. What does their skin look like? Are they pale? Are they mottled? Are they pink? Are they warm? Are they hot? Do they have a pulse? What does their overall circulatory status look like? And what do you need to do about that? So are they super dry? Put some lines in them, give them some fluid, hydrate them up. So that's kind of the basic airway breathing circulation assessment that I do on all of my patients. And again, that takes usually a couple minutes when you walk in and you can say, hey, how are you doing? And they respond, they have a good conversation, and their O2 sats are good. Their skin looks good. You don't need to do anything, but it's the sick patient that you have to pick out. The patient, when you go in and they're not really responding, they don't have an adequate airway, you have to set up for intubation. They're not breathing, you have to breathe for them. They're super dry, they're mottled, they're septic. You have to put some lines in them and give them some fluid, resuscitate them. That's kind of the approach to the sick patient and a little bit of the management there. So now we're going to talk about some procedures. So this is probably going to be one of your best friends in the emergency department, and it's the bedside ultrasound. And I was trained on this in school. The bedside ultrasound is great. You can do so many different exams with the bedside ultrasound. You can do, in trauma, you can do a fast exam. Outside of trauma, I use it all the time. You can do a bedside cardiac ultrasound. You can just get a really good view of the heart, estimate the ejection fraction. You can see if they have an effusion. You can see what their valves look like. You can see if they have a great big heart and they might be in an acute CHF exacerbation. There are just so many things you can see with the bedside ultrasound. Apart from that, you can do renal ultrasounds, you can do OB ultrasounds, you can do Doppler studies. There are just so many uses for the bedside ultrasound. And if you're not trained in that, I would highly, highly recommend you go to a course. There are courses that offer training in bedside ultrasound. I'm sure there are YouTube videos that offer training in bedside ultrasound. I don't know of any off the top of my head courses that do that, but there are courses out there that can train you. And it's well worth your time because like places like remote Alaska, they have a bedside ultrasound, you're golden because you can do a lot with that. Put it in central lines, put it in peripheral lines, whatever you need. The bedside ultrasound can usually help. Next would be airway management. I say next, not next. Airway management, there are two different types of blades that we use to manage airways. The first is a MAC blade. So a MAC is a curved blade. As you can see the little curve there, it's a MAC blade. And the next would be a Miller blade. And so a Miller blade is straight. And as you can see there, there's really no curve to that. That's a Miller blade. Then you have a handle, laryngoscope, and a blade attached. So that's what that would look like. You always want to make sure light works. When you get in there to intubate somebody, you really want to be able to visualize the cords with that light. So that's a little bit about what airway equipment looks like. You also want to have some airway adjuncts set up, so you can have like an oral airway, a nasal trumpet, a bougie. Worst case scenario, you could have a glide scope. That's Pretty cool right there. I prefer direct visualization, so a MAC 4 on an adult will usually get anything done. You can usually visualize the cords. If you anticipate a difficult airway, that's another circumstance that's kind of scary. If you anticipate a difficult airway, have all your resources available. So have oral airways ready, have a bougie ready, have suction, obviously, a bag valve mask, probably have some experts come down if you're in that or if you have that availability in your facility, have anesthesia come down. Otherwise, have everything set up, including a cric kit. So worst case scenario, you can't oxygenate, you can't ventilate, meaning you can't pass the tube, you can't bag the patient, you're gonna have to cut. And so you cut right above the cricothyroid membrane and you put a tube in there. That's, again, worst case scenario. You don't want to be cutting on anybody's neck, but if you can't oxygenate and you can't ventilate, that's really your only choice. The other thing we do would be chest tubes. So this is what the chest tubes look like. You would have a chest tube kit set up, hopefully, and you would make an incision at the mid-axillary line around the 4th, 5th intercostal space. You would blunt dissect down to the chest wall, puncture through the chest wall, slide in the tube, hook it up to a pleurovac. Very simplified version of what a chest tube is. Before that, though, if you think they have a tension pneumo and you're in like a trauma situation, people just don't randomly get tension pneumos. Usually it's traumatic. You'd want to decompress that first. So needle decompression followed by a chest tube. Again, that's not really your standard ER procedure because not everybody gets a tension pneumo. But if that's the case, you really need to be thinking about decompressing it before you put in a chest tube. Central lines, we have a central line kit here. So triple lumen central lines, again, use the ultrasound for that. It's going to be your best friend. Typically, people go to the IJs now, ultrasound guided. Way back when, subclavian was kind of the favorable choice, maybe femoral. That's really gone out of favor now. People really opt for the IJ using ultrasound guidance. And so that's what I do. And you can't really go wrong with that. So we also have stuff set up for needle decompression, as you mentioned earlier. You can use just a 16 gauge or a 14 gauge IV. They also make these chest darts. I've never used chest darts before, but it's basically the same idea as a large bore IV catheter hooked to like a stopcock with a syringe. Decompress the chest while that's happening, have somebody else be setting up for a chest tube and throw the chest tube in the patient. Hopefully you're not doing all of that. That's a bad day for somebody. Good day for you, get a lot of procedures in, but usually a bad day for the patient. So that's a little bit about procedures and kind of how we care for the critically ill patient in the emergency department. And again, not every patient that comes in is critically ill, but you have to have that on your radar. Again, it doesn't happen every single patient you see, but you are going to be managing critical patients every shift if you work in the emergency department, and you have to be really good at managing critical patients because those are the ones that like to die on you. So that's a little bit about what it's like to work in the emergency department. I would love to hear your feedback, so please comment below. Let me know what you think about working in the emergency department. If you're an ED provider, please comment below. I'd love to connect with you. If you want to work in the ED, comment below. I'd love to hear what you have to say about it. Thanks so much for watching, and I will see you next time.